Ted, we've seen a lot of discussion around site-neutral payments and trying to reform this disparity that existed between what oncologists were being paid in the hospital and what they're being paid in the community setting. Can you talk a little bit about what I mean by site-neutral payments? Why did these disparities exist in the first place, and what happened recently to do something about this?
Right. Well, they're actually not site-neutral payments. That's what
right.
we want to create.
We want to make them
there's
site-neutral.
a disparity in terms of if you look in the hospital setting. I'm talking about the hospital outpatient setting, and you go into the hospital outpatient, and for example, you get chemotherapy, and there's the first hour payment for the first hour of chemotherapy by Medicare. It's extremely higher than the payment that you get when you go into an oncologist's office. And let me tell you what's interesting about this. As more hospitals purchase oncology practices, I have seen patients that from one cycle to the next, they go into their oncology practice, see their doctor, get the chemotherapy administered, walk out of the building, and then the next cycle they go into the same building, they're seeing the same physician, they're being administered chemotherapy by the same nurse, and they get their bill, and it's extraordinarily higher because in between those cycles, and this happens all the time, that practice has been acquired by the hospital. And the hospital is billing under, first of all, a higher payment for that first hour of chemotherapy, and then they're adding on a payment for a facility fee under Medicare. So, you know, this is one of those things of, Scott, I couldn't tell you how it's evolved as much as it's evolved, especially because the hospitals say they need higher prices because they have to subsidize their emergency room and they have JCO accreditation issues. But the problem is that there is this disparity and it's costing Medicare a lot of money. So what was interesting is, and very interesting, and it caught a lot of people by surprise, except us, is that in the Balanced Budget Act that the president signed back in November 2nd, what happens is any hospital that's in the process of acquiring a physician practice or acquires a physician practice going forward or has an off-campus facility, that's defined as being 250 yards from the sort of the main building, come 2017, instead of billing under that hospital fee schedule, which is a higher payment, they will have to bill under the Medicare physician fee schedule, which is a lower payment. So even though we would like to see payments and we think payments should increase on the physician side, what this has done is it's the first time that's created actual payment parity. Now, sites that were already acquired are grandfathered in. We'd like to see that change, but right now, at least going forward, we will see as CMS basically digests this and figures out how they're going to administer it. In 2017, there will be site payment parity on Medicare going forward. It's a big step.
And do you think that's going to intensify the acquisitions of private practices up until December 31st of 2016?
No, here's the problem. Here's the problem, John, and this is why some are upset about it. When the president signed, the second he signed that law into effect, that's of that moment. So literally, if an hour later there was a practice that was acquired and then put on the hospital cost report, they will be billing 2017 under the physician fee schedule. Okay. So if you didn't do that, in fact, a lot of people have said, why wasn't there a grace period? You would see this huge influx of acquisition activity happening. And at least Congress did the right thing. For once lately, they did the right thing in terms of actually saying, no, it's when the president signs law.
Of course, there was a deluge of practices getting acquired the day before it signed. I'm just kidding. So the practical effect is going to be that you're probably going to see the number of practices that get acquired by the hospitals go down somewhat, because in some cases they were playing this arbitrage, if you will. Although there's other things like 340B, other reasons why hospitals might want to get practices.
I think what this does is, if you look at this as being sort of a hemorrhage of practices. So if you look in the oncology space over the last 8 years, we've basically seen close to 500 practices, multiple sites acquired by hospitals. And it's a big problem because we see consolidation. We also see over 300 clinic sites that have been closed. So, but the problem is, in this hemorrhage, this is a nice little Band-Aid. Don't get me wrong, and there's a little stitch in there, one or two, but the biggest driver of acquisitions now is 340B, because if you think about it, the economics are really simple here. An average oncologist can account for about $4 million worth of drug a year, depending on what he or she treats, what types of cancers, and therefore what drugs they use. So if you look at 340B discounts, which are between 30 to 50%, and on the brand side average out around 40% or so, but can go up to 50%, you're looking at $1.2 million to $2 million of huge profit right to the bottom line. And you just talked about arbitrage, Scott. I mean, this is the biggest form of arbitrage there is. So the biggest driver in consolidation is still on that level. And in fact, a report just came out from the Berkeley Research Group, and this is very interesting, that almost 25% of all Medicare Part B is 340B. Almost 25%. If you look at just the outpatient setting of hospitals, over 60% of the oncology drugs are 340B discounted. So it's something that's unsustainable and has a lot of unintended consequences.
What do you think some of those consequences are with respect to patient care? We are seeing more of the delivery of oncology go into the hospital setting. Has that had any observable impact?
I think the most immediate effect of this consolidation has been closure of a lot of rural clinics. And with this new law, I don't see, it may be still that facilities that own providers still have an incentive to create clinics in rural settings, but they're not going to get that facility payment and they're not going to get the enhanced payment. They'll still have the 340B pricing, but not all hospitals have that. So I think maybe the net effect of this law will be to decrease access, or at least it won't improve it.
Well, and I think the other interesting thing is, so if you go back 40 years ago and we think about what cancer care was like, it was really centered in a lot of big facilities, and patients had to travel, and you didn't have it in the rural area. And what's kind of ironic is we've come full circle, because now we have more health systems building large buildings, and in a lot of cases, and people hate me saying this, but it's off of 340B profits. And so they're building these, and what they're doing is they're closing those less profitable rural centers, and that's where we've seen a real impact. So the irony of it is we're actually digressing back again. We're de-evolving into a system of where we're going to see beautiful buildings and you know, providing cancer care, but more centralization and less basically out in the community in the rural settings. And that's disconcerting, because what that means is a lot of people think when a cancer patient has to travel, they will do anything. And study after study have shown that no, in many cases they can't, they won't, and it only ends up where their disease progresses and they end up in the emergency room somewhere, that they're in the hospital.
What are you saying?
So I think that there's also an out-of-pocket cost differential to the extension that some of these, and it'd be interesting, Ted, you know, there's been like kind of statistics on how quickly the field of oncology is migrating into the hospital outpatient setting at a kind of a rapid clip, and I've seen varying estimates, but out-of-pocket costs could certainly change if patients are on the physician fee schedule and subject to kind of Part B kind of premiums and co-payments, which we know has also been changing just from a Medicare standpoint. So in the end, how a patient might see this, I think you're absolutely right. Patients prefer to stay local. Will they have those local options? Maybe not as a result of this. And will they also then potentially be subject to some out-of-pocket costs because they might have, you know, not the hospital-based facility, but something that's on the Part B sensitivity. So I think there's some interesting kind of dynamics, but I agree with Ted completely. When I saw this, first of all, it's interesting, I'm not defending kind of these larger institutions. They hate this term site neutrality because they think it really takes away from what they see as some of the differentiators, the academic setting, the teaching, multidisciplinary rounds, et cetera. So when you talk to the larger institutions, they're very upset because they think that this conversation around site neutrality just kind of takes everything to a lowest common denominator when they really do feel like they offer something that's truly different. My retort back to them is, you'll have to demonstrate that you really offer something different to your original example. Right. But I think on the patient side of it, here's what's interesting that we haven't, you know, kind of dissected. when you talk to ethnic groups and minority groups, there's a palpable perception that the institution-based treatments are sometimes better. It's the same reason that we see ethnic minorities going to the emergency rooms for care. They feel like their care is actually better and that they can get all their services delivered in one setting. So I think that as we know that there exist disparities of many kinds, disparities of care delivered in community-based settings versus hospitals, there's also kind of another exaggeration of disparities kind of along racial and ethnic minority lines. And it leads a little bit to the rural conversation where we're making things a little worse at times, I think, with some of these policies.
We are. I think the biggest thing, the driver overall is, again, and I'm saying there's many hospitals that provide the greatest care in cancer care, but the problem is it's well known that the hospitals basically cost more for Medicare, for the private payer, but most importantly for the patient. So if you look at studies by Milliman, Avalier, Moran, BRG, go right down the list of big, well-respected national policy firms have looked at this and shown there's higher care. And I'll tell you what's a little disconcerting, and it's kind of interesting. You know, the argument, the age-old argument, you think back when you were on working for Senator Kennedy and on help staff, and think of it was always this around the MMA that oncologists basically prescribe drug based on the margin. Well, in the latest BRG report, they actually found that looking at 340B hospitals versus community clinics, it cost 52% more in the 340B hospital, and they found because they use more drug and more expensive drug. And I'll tell you what's interesting about this, because a lot of people say, well, that's one report. The GAO did a report earlier this year, and the GAO came to the same conclusion.
Well, the economics are stronger on the hospital side under 340B than it ever was under Medicare, under ASP, in terms of the spread that you can capture by prescribing a more expensive drug. You know, the idea that there is an arbitrage by moving outpatient oncology care into the hospital is well known, and it's well known at this point and well accepted that a lot of hospitals, or some hospitals, were acquiring oncology practices for that purpose. I think it's not impolite to say that. One component of that was addressed with the recent legislation. There's a lot of other components, including 340B. Do you think politically these other pieces are going to get addressed? Do you think the administration and Congress have done what they're going to do to try to address this overall?
No, I think that they're certainly, I would say that a lot of these movements into specialty payment models and just in general this conversation about alternative payment models will address this. So this oncology care model that John's organization is hoping to participate in, quite honestly, it was really aimed at community-based doctors, and that there's a reason for that. And so that's another example, well outside of the BBA, that the administration is trying to exercise to support community-based care for all the reasons Ted said. So I think you can expect to see in either party, whatever party comes into power in 2016, I think you can expect to see administrative actions that further deal with this. I'm just upset that it's just, you know, the whole grandfathering. I understand politically why they did that. I understand that this is why they were able to pass what they were able to pass. But it does disappoint me because, and if you look, just we've been talking about oncology. Cardiology is probably the specialty exemplar for this. I mean, this is really a big issue for, you know, cardiology, orthopedics, and oncology. And I'm cardiology the most, I would say.
Taking out the drugs, the cardiology, if you look at just the pay, the differentials are bigger on the cardiology side than even the oncology side.
And I'm disappointed as well, too. I agree with you, Kavita, but at least I say this is, and it's a big step.
And I was shocked that there wasn't more reverberation, which tells me that this is an acknowledgement on the kind of private industry side that this is happening. So that to me was a...
And you know, I'll add another thing too, is that if you look at what MedPAC recently met, they talked about 340B.
Oh yeah.
And they talked about literally bringing down that delta between the reimbursement, sharing it with the beneficiary and Medicare. Well, if you look at the OIG work schedule for 2016, they're looking exactly the same thing.
Well, and HRSA hasn't, the comment period is closed, but HRSA's got the 340B regulation.
The problem is that the guidance is just guidance. And I commend HRSA that I think they went as far as they can.
But I think that's something.
No, I think it is. But I think what you're going to see, this is my prediction, when you see MedPAC, when you see OIG, and I
Right.
can tell you, I had a discussion with a member of Congress just the other day that is looking at this 340B, and actually even on both sides of the aisle, I think it's only a matter of time because I think it has
Senator
gotten so
Grassley for
big.
years has been.
Absolutely,
I mean,
but
there
now
are
you see some other
Right,
members
right. But I
that
mean,
you
this-
wouldn't
this is-
expect that have this as an issue and say,
Right.
this has got to be corrected.
You think patients are aware of this, these site of service differentials, and
No, I don't think they are. I don't think there's good transparency around costs by different sides of care. As a health plan, we've been very proactive in publishing costs for different procedures, elective procedures, shoppable procedures. But site of service is only recently becoming an area where we've begun to focus attention on the cost differentials and even creating incentives for patients to go to lower cost sites of care. Ironically though, while we may create incentives to go to an ambulatory surgical center, and people and hospitals may label places as ambulatory surgical centers, they bill under the same tax ID, so they're billed as a hospital rather than an ambulatory
But
surgical
you know what's
center.
interesting is,
Yeah.
so United in Oklahoma has done something in terms of incentivizing patients to basically go to that, to literally go to the, in essence, the physician's office than the hospital. And so I think you're seeing, and I've talked to some other payers, you're seeing some movement in that area. And I don't think patients, Scott, understand at all this concept of site neutrality, but I will tell you firsthand, because my email and all my other contact information is out there on the web. I have literally had patients call who go in to see that same physician, same nurse, same building from one cycle to the next, and literally they get their bill and it is sky high. That's what they understand is when they get that higher bill.
I think the real challenge though is even if patients did know, so you're newly diagnosed with non-small cell
what are you
lung
supposed to
cancer,
do?
are you going to switch doctors?
That's
Because,
exactly right.
and I don't think that's going to happen. So I think it's still going to be the luck of the draw. Do you get a lower cost side of care or a higher cost side of care?
That's right.
right?